Namaste, Professor Ganguly, sir.
Hello. Namaskar. Good evening, Dr. Kanagavelu.
Evening, sir.
After a long time,
Thank you
I've
for
been
joining.
so much.
Been quite some time, so I just wanted to see you and talk to you. That's the reason I called you
Thank
only.
you so much. Thank you so much for calling me. Am I audible?
You're perfect, sir. Your connection is good.
Okay.
You are able to hear us well.
Okay. Thank you so
Sir,
much.
you're right now in Jorat or where, sir?
No. I'm not in Jorat. Last 2 years, I am in Nalbari Medical College. It's a rural
Okay, sir.
medical college. Yeah,
Okay, sir.
Nalbari Medical College. Yeah, not in Jorat now.
Okay, sir. We have 2 more minutes, sir. We'll start on time, sir.
Yeah, sure.
Ganesh, sir, good evening. Madan? All right. Good evening, friends. Warm welcome to all of you for this PG clinics. We are very, very glad that we have crossed 600 cases last week. We are now into the 602nd case being discussed.
Very
Thank
nice.
you all the faculty, national faculty, international faculty, and dear student residents who have been the pillar of getting the show going on and on. Warm welcome, sir. Professor Rahul Khanna, sir. Namaste, sir.
Good evening, sir. Good evening.
Good evening, sir. Professor Kirit Parmar, welcome, sir.
Sir, good evening. Thank you.
Good evening. So, we are on to the 602nd and third case for the entire PG clinics. We have very eminent faculty team here, both seniors and youngster. We have Professor Narendranath Ganguly. He is an eminent professor of surgery. Earlier, he was in Jorat Medical College.
Hello,
Now he
everyone.
moved into the other hall. Thank you, sir. Thank you for joining. Professor Navneet Kar is expected to join a little bit late. Professor Rahul Khanna is
Hello.
again professor of surgery from Institute
Evening.
of Medical Sciences, Banaras University, Varanasi. We have Professor Akash Rathod from Narendra Modi
এতিয়া
Medical College,
কথা পাতিব
Ahmedabad.
নোৱাৰিব মই এটা মিটিঙত আছো
And very important, we
দুঘণ্টামান
have
পিছত
one of the star youngster who stood first in the NEET SS exam and took MSH in surgical gastroenterology in AIMS Delhi. And later he moved on for a brief stint, and then now he's with Max Healthcare. And his classes and his preparatory advices online are much, much appreciated. So we thought we'll have one youngster colleague so that it helps the students to think in a younger perspective also. So without much ado, I will start the session open up. And we have Dr. Vedant Shah. Vedant Shah is kindly contributed with Professor Hitesh Andarya sir and the professors of his unit from Narendra Modi Medical College. He is going to address us a case of right leg fossa mass. And second case will be discussed by Dr. S. Madan Kumar, kindly contributed by Professor Pabita ma'am and Professor Irene ma'am. So he is going to discuss a case of carcinoma breast. So those who are watching, if it is possible as a request, kindly share this class information. Now we move on to the next session, the first case discussion by Dr. Vedant. Vedant, please introduce yourself, your unit faculty and head of the department. Start your presentation. Good luck to you, Dr. Vedant.
Thank you, sir. Good evening, everyone. I'm Dr. Vedansha, third year resident general surgery from Shet LG Hospital, Narendra Modi Medical College, Ahmedabad. My PG guide is Dr. Akash Rathod, sir, and head of the unit is Dr. Hitesh Andarya, sir. I will like to proceed with the case. A 55-year-old male patient resident of Ahmedabad working as a mechanical engineer came to surgery OPD with chief complaint of fullness in right lower quadrant since 15 days. Patient was relatively asymptomatic before 15 days. Then he noticed lump over right lumbar region and right iliac fossa, which was insidious in onset, gradually progressive, and increasing in size to current size of 18 to 5 centimeter approximately. One episode of fever 15 days ago, for which he took over-the-counter drugs from the chemist. Patient had no history of abdominal pain, no history of vomiting, no history of constipation, no history of diarrhea, no history of significant weight loss, no history of melena or bleeding per rectal, no history of anorexia, no history of disappearance of swelling after micturition, no history of night sweats. In past history, no history of similar complaints before, no history of previous surgery. Patient is a known case of hypertension and diabetes mellitus since 1 year and on treatment with no complications. No history of travel and no history of tuberculosis. Family history is non-significant. Personal history, patient is taking vegetarian diet with adequate appetite and unaltered bowel and bladder habits and sleep pattern. Patient had addiction of chronic BD patient is a chronic BD smoker since 40 years. Summary of the history. 55-year-old male patient, resident of Ahmedabad, working as mechanical engineer, came to surgery OPD with complaint of lump over right lumbar region and right iliac fossa, which was insidious in onset and gradually progressive and increasing in size to current size of 18 to 5 centimeter. And one episode of fever 15 days ago, and no history of vomiting and constipation. He is known case of hypertension and diabetes mellitus. On general examination, patient is examined after receipt of informed consent in a well-lit and well-ventilated room with proper exposure. Patient is conscious, cooperative, and well-oriented to time, place, and person. Patient is well-built, BMI of 32. Vitals, temperature normal, pulse rate of 76 per minute, blood pressure of 136 by 86 mm of Hg, respiratory rate of 20 per minute. And patient had no pallor, icterus, nail clubbing, lymphadenopathy, pedal edema, or cyanosis. On inspection, a well-defined smooth ovoid lump over right iliac fossa and right lumbar region of approx 10 into 5 centimeter. No movement with respiration, no impulse on coughing, skin over the lump normal without any redness, dilated veins or pigmentation, no visible peristalsis or pulsation. Lump decreases in size on leg raising test. No visible lymphadenopathy over left supraclavicular region. Right side flank fuller than left side. Hernial sides normal and back and spine normal. On palpation, all inspectory findings are confirmed on palpation. No tenderness or local rise in temperature. Lump palpated over right iliac fossa and right lumbar region of size 10 into 8 centimeter with smooth surface and tense with well-defined margins and firm in consistency. Lump is non-mobile, superior and inferior and medial margin well-defined. No cuff impulse. Fingers can be insinuated between lump and inferior margin of liver. Lump is not palatable. No organomegaly. On percussion, dull note percussed over lump. No shifting dullness or fluid thrill. Tympanic note in rest of the abdomen. Liver span normal. On auscultation, bowel sounds heard and normal in frequency. Systemic examination, digital anorectal examination, normal anal tone, no prostatomegaly. On proctoscopy, no any abnormality noted. External genitalia examination normal. Cardiovascular system S1, S2 heard and no murmur. Respiratory system bilateral air entry present.
Hello, Raman. হ্যাঁ
Provisional diagnosis, lump is
ঠিক আছে
right
that will be
lumbar
better
and
I think
right iliac
ঠিক আছে
fossa,
Raman,
probably arising
thank you
from
so
ascending
much
colon or idiocecal junction or appendix.
ঠিক আছে okay bye.
Did you examine the renal angle in this patient?
What, sir?
The renal angle. You have not
Yes, sir.
commented on the renal angle.
On a renal angle percussion, the resonant note was present.
Okay.
We go back
And,
to the negative history.
Was the lump tender or not?
No, the lump was not tender.
Okay. So,
What is band of colonic resonance?
Band of resonance is it can be seen in mesenteric cyst when there is a dull note in the middle and surrounding it is resonant in nature.
Mesenteric
For the
cyst.
mesenteric cyst?
No, sir.
Band of
Band of
Band of colonic resonance.
On percussing over renal angle, there is ascending colon present there. So there will be resonant sound. If renal mass would be present, then it will be having dull note on percussion.
No, there will be either side there will be dull note. In the center there may be resonant note because of the colon.
Yes,
The case of the large renal lump.
yes.
Okay. But in how many cases it is positive in the renal lump?
If the renal lump is not
No, in a case of a renal lump, known renal lump, in how many cases you can get the band of colonic resonance?
When the lump is smaller in size and means it doesn't push ascending colon away.
No, it is present in only about 10% cases.
Okay.
Okay, so even the known large renal lump, if you want to test this, it is only present in about 10% cases.
Yes.
What are the things you see in the renal angle?
So it is present over 12-3 by erector spiny muscle, sir.
No, what are the things you examine on the renal angle?
Mhm.
Inspection, palpation, percussion.
Yes, sir. On percussion, sir, there is a resonant note normally.
First begin with inspection. First begin with inspection.
How do you expect the renal angle to be resonant?
Sir, if there is a bulge or not present over the renal angle, it may be present in huge swellings of kidney.
What is the relationship of the erector spiny muscle with the renal angle?
It is medial to the renal angle, sir. 12-3 band.
Or so there are thick muscles at the back, isn't it?
Erector spiny forms which border of the renal angle?
Medial border of the
Medial border, yes. And the superior border is formed by?
12-3, sir.
Right. So on inspection, what do you see?
On
How does
inspection,
it look like?
there will be a triangular formation. Triangle.
If it is like a cup shaped in the normal person, it will be depressed in that area.
Yes.
On palpation, you will see for the tenderness.
Yeah.
And
Yeah.
percussion, you will see for the note of that. Normally, it is resonant on percussion, but in case of renal lump, it will be dull on percussion.
Dull. Yes, sir.
What additional finding you might get on the back from this tender renal lump? Painful tender. What additional finding in the back you might see?
Hello, Pramal, Kwa.
Sir,
On the vertebral column.
question, sir? Hello.
Scoliotic deformity can occur.
Ah,
Collision on the side.
ah.
What are the components of the Murphy's triad?
Sir, in Murphy's triad, there is raised
বাঢ়িছে ন?
temperature.
সেইটো জানো মই, এইটো পেংক্ৰেটাইটিছে আছে। তুমি
Dr. Naren,
অক্ট্ৰেটাইজ
Dr.
ষ্টাৰ্ট
Naren,
কৰি
please mute yourself. Dr. Naren, please mute yourself.
দিয়া। আৰু যদি ভাবা যে পেচেণ্টৰ কণ্ডিশ্যনটো হেৰি হৈছে,
So there is pain in
Tell us the
abdomen,
components of renal.
vomiting, and fever, sir. Raised temperature, sir, in Murphy's triad.
So is this patient fulfilling the components of Murphy's triad?
No, sir.
So what components he's fulfilling?
Only fever, sir. That only one episode, sir.
What are the other two components of Murphy's triad?
Sir, pain in abdominal pain and vomiting, sir. Which
What
usually
is the usual sequence of these symptoms in
sir, start
appendicitis?
with pain, which vomiting follows the pain, and then there is raised temperature, sir.
raised temperature? The last.
Last, sir. Raised temperature.
Okay. And what is, where do you get Murphy's sign?
Murphy's sign is catching of breath when we palpate on the right hypochondrium in case of acute cholecystitis. Shoulder tip pain, sir.
Okay. Okay. So what can be the pattern of pain in acute appendicitis? Like what are the characteristics of the pain? Location
So there is migration of
and
fluid from periumbilical region to McBurney's point, right iliac fossa. Then uh, it decreases on raising leg and flexing the leg. Then there is leukocytosis associated with pain, nausea, vomiting, and if the position of the appendix is in pelvic, then it may be associated with diarrhea.
what is characteristic of the leukocytosis seen in acute appendicitis?
There will be a shift to left side, sir.
What do you understand by shift to the left side?
Uh,
What is shifting to the left?
means there will be segmented neutrophils. Neutrophils will be raised, sir. Immature
What
neutrophils
is
will
characteristic?
immature neutrophils will increase, sir.
Immature neutrophil. What are immature neutrophil?
Sir.
What about the pain?
Yes,
Tell
sir.
us about the pain, characteristic pain in these patients.
In this patient, sir.
If you get rebound tenderness, what is suggest?
Bloomberg sign, sir.
Rebound tenderness.
Bloomberg sign, sir. When we lift the hand, then the patient complains of pain, sir. Rebound tenderness.
What is the interpretation if you get this sign?
Sir, it is called Bloomberg sign, sir. There is a peritoneum inflammation which causes the pain.
Okay, can you go back to your percussion finding? Can you repeat your percussion finding that you got in this question? Percussion.
There is dull node percussed over lump, no shifting dullness or fluid thrill. Tympanic node in rest of the abdomen and liver span is normal, sir.
Did you try to look for masking of the liver dullness?
Yes, sir, but liver dullness was not masked, sir. It was normal in span, and there you can insinuate the fingers between the lump and the liver, sir.
What is normal liver
Okay.
span?
Uh,
What do you understand by normal liver span?
it is, sir, distance between the upper and lower border of the liver, sir.
But what is that normal?
Sir, 6 to 12 centimeters, sir.
6 to 12 centimeters. Where?
In, sir, mid-clavicular line, sir.
It's usually 9 to 11 centimeters.
Okay,
In mid-clavicular line, 9 to 11 centimeters.
okay,
What
sir.
are the other places where you can see the liver span? Apart from the mid-clavicular line. Like if there's a gallbladder lump is there, will
Yes.
you do the liver span in the mid-clavicular line or not?
No, sir. It will not be.
So then where you will demonstrate?
Sir, I don't know, sir.
You can go to the anterior axillary line.
Yeah. Okay.
You can go to the mid-axillary line. Okay.
Okay.
What do you see in this patient where there is a lump in the right iliac fossa on the spine?
Just a second, sir.
What you will see in the spine in the patients with the lump in the right iliac fossa.
Sir, it can be lumbar hernia, sir. Psoas sepsis. Psoas
Spine.
sepsis.
I'm asking about the spine.
Spine. Sir,
Lumbar
POTS,
abscess within the renal angle.
sir, POTS spine, sir.
Hmm?
POTS spine,
Port
sir.
spine. What is the other name of the port spine?
Uh,
What is gibbous deformity?
gibbous deformity, sir.
So what type of the gibbous deformity it is? Which type of the spinal deformity is the gibbous deformity?
Sir, there is a sharp angular, sir, deformity, sir.
So what type of the deformity is it? Is it the kyphosis or lordosis or
Kyphosis, sir.
scoliosis?
Kyphosis, sir.
The kyphosis.
Yes, sir.
Okay.
Okay, so now can you summarize your case, including the examination findings? Summarize your case.
Okay. So just a second, sir. I was having some tech. Yes. Sir, a 55-year-old male patient, resident of Ahmedabad, working as mechanical engineer, came to surgery OPD with complaint of lump over right lumbar region and right iliac fossa, which was insidious in onset, gradually progressive and increasing in size to current size of 18 to 5 centimeter, and one episode of fever 15 days ago, and no history of vomiting and constipation. He is known case of hypertension and diabetes mellitus, sir.
No, the examination also is summarized. Summary of the examination findings.
Dr. Vedant, Dr. Ganguly here.
Yes.
Your history says that it is a lump of insidious onset, but you have said that the duration is only 15 days.
Yes, sir, it was gradually increasing in size, and patient complained of abdominal fullness first, then complained of lump, sir.
No, insidious onset and 15 days duration, and it has reached to the dimension. These two are contradictory, right? If it is 15 days, then it is an acute lump. If it is an insidious onset and progressively growing, then it is a chronic lump. Do you think both types of lumps should be evaluated similarly?
No, sir.
So what do you suggest when a 15 days lump, which has reached almost 8 by 10 centimeter, be of origin of?
Sir, it may be inflammatory or infectious, sir.
If it is inflammatory, so did you find any signs of inflammation here?
No, sir.
So don't you think that somewhere something is not fitting?
Yes, sir.
You have not mentioned about history of any hematuria.
Yes, sir.
Can you go back there? In the negative, no history of hematuria.
Sir, patient had no history of hematuria. I failed.
Then in the past history,
Yes, sir.
what was your intention of asking about history of travel?
Sir,
What similar complaints?
sir, there can be amoebic infection if there is a travel to.
Insidious is a thing of weeks to months.
Yes, sir.
So if your past history is in the lines of acute, then your summarization should not have insidious.
Right, sir.
And what family history were you specifically looking here for? Next, you have mentioned as no significant family history.
So in family,
So if you by the end think along the lines of insidious and malignant, you should mention of malignancies in the family, like colon cancer, like. So no significant these GI malignancies. If you're thinking of something travel related amoebiasis, then
Sorry. Natural.
And also twice you tried to exclude tuberculosis on a lump which is of only 15 days of duration.
other family members presently.
Sorry, sir, I didn't get it, sir.
Tell us the differential diagnosis of this lump.
Yeah, that is another thing,
What's the
Dr.
differential
Khanna.
diagnosis?
The provisional
Yes, sir.
diagnosis looks like a differential diagnosis.
Yeah, what's the provisional diagnosis you made?
It looks like a differential diagnosis.
What,
Go to provisional
I couldn't
diagnosis,
hear it.
Dr. Vedant. Go to Dr.
Yeah.
Vedant.
Can you
Please
go
go
back?
to
Yes, please.
provisional
Repeat it again.
diagnosis.
Yeah.
Provisional diagnosis.
Yeah, I couldn't. Yes, let's see your provisional diagnosis. Just lump in right, lumbar in. See, you need to make a diagnosis. This isn't a diagnosis. This you're
Yeah,
saying there's a lump arising from appendix or adduction. That doesn't mean anything. You label according to the probability. What is most likely, then make 3 or 4 diagnoses of a right iliac fossa lump. This isn't satisfactory. You come to a diagnosis. Like acute appendicitis is a diagnosis. This is not a diagnosis of lump arising from appendix.
right.
So you make a diagnosis of appendicular phlegmon or something like that. You make a diagnosis right now.
Oh,
So
Dr.
tell us the
Vedant.
diagnosis. What do you feel is most likely?
Yes, that is the thing.
sir, most likely it is arising from bowel on right
No,
side,
that
sir.
is not a diagnosis arising from the bowel. That is, you say a particular phlegmon or appendicular abscess or idiopsychotic tuberculosis. That is a diagnosis. So tell us what is most likely.
More likely, sir, it can be carcinoma of colon on arising from ascending colon, or ileocecal tuberculosis can be there, and uh, there is appendiceal mass, appendicular
Dr.
mass.
Vedant. Dr.
Yes,
Vedant, may I?
yes,
Dr. Vedant, your history and examination, nothing suggests that the lump is from the gut. And your provisional diagnosis, you have used 3 diagnoses, all are gut.
sir. From negative history, sir, we deduced that it was not arising from kidney or liver, so it might be arising from the bowel, sir.
But there should be bowel complaints, no?
Yes, sir.
Don't you think acute appendicitis with lump will have definite bowel problems? Ileocecal junction, definitely there will be bowel problems. Ascending colon related lump, definitely there will be bowel problems. But you
Yeah.
have given all the provisional diagnosis which is not tallying with your examination and history. Just ask yourself, why not retroperitoneal lump?
Sir,
Yes.
retroperitoneal lump can be a diagnosis, but patient was examined on left lateral position, and the lump was mobile, sir. Was not mobile. So we ruled out retroperitoneal tumor, sir.
How can you rule out when it is not movable? Do you think retroperitoneal lump will move?
No, sir. It will, sir. It can be done in knee elbow position. If it is intraperitoneal.
Is it done at all nowadays?
No, sir. Now it is not done, sir.
Then did you do
Left.
it? Did you
No,
do
sir.
it?
No, sir.
Then no ifs and buts. Question to this patient. The sir is asking why not other things other than bowel, which the symptoms do not correlate with your history. Why not other things? What other things you have to think of other organs and probable etiology at this age?
Sir, retroperitoneal mass can be there's a retroperitoneal lipoma or retroperitoneal liposarcoma or retroperitoneal sarcoma, sir.
Don't give histopathology. Retroperitoneal mass. That's it. Anything
Okay.
Yeah,
else?
that's it. Yeah.
Retroperitoneal mass can be there. Sir, it can if it is infectious, then psoas sepsis can be there, sir. Psoas sepsis or ileocecal tuberculosis or appendicular mass.
How we can diagnose psoas sepsis?
So psoas sepsis, there is fluctuation present over inguinal ligament. Cross fluctuation is present.
But Dr. Vedant, you have had two questions.
If
You
it
have
is
asked categorically to exclude tuberculosis. That means the patient doesn't have evidence of tuberculosis. So why will you think psoas sepsis? Which is the commonest cause of psoas sepsis?
Pot spine, sir.
So that's it. You have taken history. So in
Right.
your history, it seems like you are trying to establish that the patient either has or doesn't have a tuberculosis. So why? Is there any lead? Patient had night attacks, night sweats, or
No,
history of
sir.
tuberculosis in the family, something like that?
No, sir. No.
All right. All right. Well, the patient was anemic.
No, sir. Patient was not anemic, sir.
So a patient having right iliac fossa lump, which is fixed to the deeper tissue, no bowel signs, no hematochezia or melena, you say,
Yes, sir.
and there's no hematuria, there is no spasmodic colicky pain, and patient doesn't have any bowel symptom or dyspepsia. Do you think it is related to bowel? So I think from the history, I'll say that it's something like retroperitoneal mass.
Sir, it can be from appendix as if it is from appendix, then there will be
There
exophytic
is
mass,
only one condition where you can get appendix, such a big lump is mucocele of appendix.
mucosal of appendix, sir. Right.
The other lumps will be much earlier operated upon.
Yes, sir.
So that's why I'm just to ask you that logically speaking, what should be your provisional diagnosis? Because your provisional diagnosis come as a differential diagnosis. You have given three organs, huh?
Right, sir.
So that's why what do you think provisional diagnosis? See, provisional diagnosis may not be right, because
Yes.
after that we'll have a long list of differential diagnosis. The wider the net, the more you will catch the diseases. And after that, we'll do investigation and establish our diagnosis. That is the simple procedure. So that's why your provisional diagnosis should have been something. It doesn't mean whether it is wrong or right.
Right.
These are the problems of knowing prima facie the investigations
Yeah.
which you have before taking
Mhm.
history and before coming to the provisional or
Yes.
working diagnosis.
Yes, exactly. I think we should go to investigations now, I think.
What will you do now?
So we can take patient for a CCT APK. We can plan a CCT APK pre-professor.
Same thing I'm telling you. Don't go to the investigations you have done.
Yes, sir.
Tell us which investigations you will do in order of preference.
That will be much
First,
better.
USG APK to localize the
Don't
organ
use
of
words like APK. Don't use short forms
Okay.
like USG APK.
sorry,
Say
ultrasonography.
ultrasound abdomen.
Yes, sir. Ultrasound abdomen, pelvis and kidney to know the origin of the lump, the organ of origin.
Yes.
How accurate is ultrasound in right iliac fossa large lump?
Yes, sir. Sorry.
How accurate is ultrasound guidance or diagnosis over a lump of 10 centimeter, 5 centimeter size present over iliac fossa? It's a very compressed area, no?
Yes, sir.
So how accurate the ultrasound will be? Not very accurate, because
Yes.
the lump will compress everything.
Yes,
So
sir.
you are
That
doing a
is that
CCT
is what
scan.
the report says. That is again
Yeah.
what the report says as per your
So
findings.
you
Yes,
go to
sir.
the next one, CCT. Show us CCT.
Plates. if you can zoom few important images, that will be good for us.
Yeah. These are large relevant image, as Dr. Andaria pointed out.
You can zoom in your screen
Yes, sir.
if possible.
So read that, the findings, salient findings. What do you see?
The well-defined lobulated marginated fluid density lesion in lumbar and iliac fossa region on right side in post-ilial location, probably arising from mid-body of appendix. Possibility of mucocele of appendix appears likely. However, low-grade mucinous adenocarcinoma can't be ruled out. Exophytic lobulated evidence of 14 into 11 into 15 centimeter sized well-defined lobulated marginated fluid filled density of Howell's fluid unit 16 to 20 lesions seen in lumbar and iliac fossa region on right side in post-ilial location with few calcific foci within its walls, normally arising from mid body of appendix. No evidence of internal solid enhancing components seen within it. Distal tip of appendix appears normal, measures 5.5 mm, sir.
So properly taken history and analyzing a history, you don't need investigations. You can come to the diagnosis. Don't you? So if it is a mucocele of the appendix.
Mucocele of appendix to this size.
So after that, did you explore?
Yes, sir.
And result, finding?
So there was a cystic mass of around 15 into 10 centimeters in right paracolic gutter, rising from cecum, and ascending colon and cecum was pushed medially and upwards, sir. And the location was subhepatic.
So the cyst originated from
Appendix.
appendix. So it
Appendix.
was a mucocele appendix
Yes, sir.
on exploration.
Yes, sir.
Okay, very good. Well done.
Show the image if you have.
Yes, sir. Is it visible, sir?
Did you see the base of the appendix, the place where the appendix joined the cecum?
Yes, sir.
What did you find there?
So the base was of around 2 centimeter and was adhered to the ascending colon and ileum, sir.
No, was
Cecum,
there a
not
growth
at-
at the base of the appendix or at the cecum? Was there a cecal growth occluding the parental lumen opening of the appendix in the cecum?
Sir, I cannot. Can you repeat?
Was there a malignant growth in the cecum which is occluding
No,
the
sir.
appendix opening into the cecum?
No, sir. There was no mass, sir, in the cecum.
So, how did the mucocele occur if there was no obstruction at the base of the appendix?
But sir, there was no obstruction in the. There was no mass or anything in the cecum, sir. No lesion in the cecum.
Was there any growth at the base of the appendix,
No, sir.
like
No
a carcinoid tumor or
growth of
something?
appendix, sir.
So, how do you explain
Did
the
you open
development of a mucocele?
Yes, sir.
So, how do you explain the mucocele of the appendix without a obstructing lesion?
Sir, it can be due to hyperplasia in the increased secretion. It is a retention cyst, but there was no, sir, no obstruction at the base,
If there is
sir.
no obstruction, all that fluid will drain into the cecum, isn't it?
Yes.
The base of the appendix has to be obstructed, only then the fluid will collect in the appendix.
Yes, sir.
If there is no obstruction, why will it distend the appendix so much? It will all drain into the cecum and go out.
Did you check for the appendicolith in this patient?
Mm. It was not present, sir.
Did you open the specimen?
Yes, sir.
Did you open the lumen of the appendix?
Yes, sir.
And there was no appendiculate.
No, sir.
What did you found?
What, sir?
What did you found on
Sir,
opening of?
on
And
opening
what did you do
the
first of all? What did you do? Did you do
uh,
appendicectomy or you did something else?
no, sir. We did ileocectomy or quadratic colectomy. With keeping 5 centimeter margin.
Why?
Sir, for frozen section, sir, we sent it for the frozen section.
No. You did not do it for frozen section. You did it for something else.
So there, if there is a chance of malignancy,
No,
so
ifs and but. What did you do in this patient? And why? The base, around base of the cecum, the lump,
was
that is mucosal, was adherent at the cecum and terminal ileum, which was not separable. That's why the segmental resection was done,
yes,
right? And what was
yes,
the content in the cystic lesion of appendix?
the gelatinous material, jelly-like material, sir.
Did you find it in peritoneal cavity when you explored the abdomen?
No, sir.
If you found it and if it is ruptured, what are the possible complications?
Sir, pseudomyxoma peritonei can occur, sir. It
When
can,
when when you will you have it?
sir, after around 5 to 6 months, sir. It will be gradually increasing in abdominal pain and
Answer the questions which are asked only.
yes, sir.
Can it be carcinoid?
Yes, sir. It can be carcinoid, but sir, the
This
mean
big, this big, this big.
no, sir. The mean size is 2.5 centimeters, so it cannot be carcinoid, sir. Of the carcinoids.
Did you have a look at the liver?
Yes, sir. No secondaries were found.
Be obstructing and produce this bigger mucosal. So there has to be some obstructive element, or the obstruction may have got relieved. But if it would have been relieved, then the mucosal would have drained itself. So an appendicololith, or in newborn children, adolescents, lymph nodes, or there could be a small carcinoid. And carcinoid, suppose you find some yellow thickening at the base and some liver yellow speck, what would you suspect?
Carcinoid tumor, sir. Yellowish lesion over the appendix. We have to suspect carcinoid, sir. It is usually present at the tip of the appendix. Uh, uh, Usually, and it can occur at the body, sir. And it is usually, sir, less than 2.5 centimeters, mean size of 2.5 centimeters, sir. Carcinoid tumor.
So did you get a histopathology report of this patient?
Colectomy was done for
No, sir, the histopathological report is pending, sir. But the margins are negative, sir, of frozen section.
Which margins?
So the ascending colon and the ileal margin both were negative.
So there is a growth is there.
No, sir. No growth, sir.
Then what is the meaning of margins?
So
No, you tell about the margins only when there is a growth is there.
yes, sir.
Hmm?
You missed one CT finding. Just show the CT report and read another finding which is there in this patient.
Yes, sir.
Yeah, in the CT report, it was mentioning the gist somewhere, is it?
Exopathic lobulated soft
Ah,
tissue density lesion probably arising from greater curvature of stomach, possibility of exopathic gastrointestinal.
slow down. Listen to the questions and answer to the point. Do not read. We are not a news reader.
Yes, sir. There is evidence of 36 into 28 mm sized, well-defined lobulated marginated, mildly heterogeneously enhancing exophytic soft tissue density lesion with internal non-enhancing hypodense areas probably arising from the wall of body of stomach along greater curvature. Medially, the lesion abuts inferior margin of left lobe of liver with preserved fat plane between them. Possibility of exophytic gastrointestinal stromal tumor appear more likely over exophytic liver lesion arising from left lobe.
So did you find this tumor at the time of the laparotomy for the appendix?
Yes, sir.
So what did you do for that?
So we perform sleeve gastrectomy and send the lesion for histopathological, sir. Histopathological examination.
What were the findings
So there
on
was a
table?
pedunculated mass, sir, on the body of greater on the greater curvature uh, of around 3 into 3 centimeters, sir.
Greater curvature is very big. Where exactly on
On the
greater curvature?
body part, sir. Body of the stomach, greater curvature.
And what did you do for that?
So we did sleeve gastrectomy and sent the specimen for histopathological examination.
Why sleeve gastrectomy?
So to have a margin of around 5 centimeters, sir.
You speak the way you think without giving any knowledge, logic. Are you prepared for gist questions?
Yes, sir.
You understand what is sleeve resection of the stomach?
Yeah. Yes, sir. A linear stapler was, sir, done.
Okay, sleeve gastrectomy usually done for the where you want to reduce the capacity of the stomach.
Oh, yes, sir.
Okay, like in the bariatric surgery.
Yes, sir.
Okay. Here you will call it as a sleeve gastrectomy or something else.
Wedge resection, sir. Oh,
Yeah, wedge resection. Okay, that will be better appropriate.
yes,
If you
sir.
want to go for the margin of 5 centimeter, because you are not going to excise the whole of the greater curvature here.
Yes, sir.
You are only going for the wedge
Wedge
resection.
resection.
Yeah.
Yes, sir.
What precautions has to be taken when you are doing the surgery for the gist?
Precaution. Uh, so the tumor should not get ruptured, sir.
Yes, that is the most important one, you know,
Yes.
because once the rupture is there, it becomes a systemic disease then.
Systemic disease. Benign.
Okay. So you have to be sure that it doesn't rupture. Do you remove the lymph nodes or not?
Sir, generally, sir, gist doesn't spread to lymph nodes, sir. So lymph node resection is not needed, sir.
Okay. So if you find in your patient, is a biopsy report available for that?
No, sir. The biopsy reports are pending, sir.
Okay. What are the tumor markers you will look into this patient if the gist is there?
Sir, seek it if we suspect a wild, then dog 1 should be done, and CD34, sir, or kit or CD117. Seek it.
So is the treatment over after the excision or something else has to be done?
Sir, on the basis of histopathological report, if targeted therapy can be given, imatinib is given.
Mhm.
for-
So what are the indications of giving the imatinib?
Sir, on HP, sir, mitotic index if comes high, sir.
Mhm. What else?
Uh,
Size of the tumor, location of the tumor,
eh,
rupture of the tumor.
yes.
Okay, so all these are the indications for giving the imatinib therapy. How much imatinib you give? And for how long you are going?
Mm.
Use around 400 milligram per day for 3 to 5 years.
3 to 5.
What finding on pathological examination will tell you that the patient will respond to imatinib therapy?
Sorry, sir.
What finding on pathology will tell us that the patient is going to respond on imatinib therapy?
CD34 positive, sir. Sir,
Anything on
CD117 positivity, sir.
exactly?
It
It
gives
has
good.
to be CD117 positive. Only then it will respond, isn't it?
Yes, sir.
So what finding? What is the histology report in this patient?
Sir, histopathological report, sir, is pending, sir. Patient was operated 2 days back, sir. Yesterday.
Okay.
This stomach lump was not palpable, right, Vedant?
No, sir, it was not palpable, sir.
All right.
Now, if this is a patient, the mucocele of the appendix is there, and you find that there is mucinous thing which is there in the peritoneal cavity.
Yes, sir.
What are you going to do?
Sir, intraperitoneal chemotherapy and cytoreductive surgery, sir.
Mhm. So what do you understand by that?
Heated, sir, in the heated intraperitoneal chemotherapy, we instill the I
What is HIPEC?
right.
Dr. Veda, there are two pathologies here. Can you give a single diagnosis to explain both of them together, or there are two independent diagnoses in your opinion?
Carcinoid tumor can be, sir, the neuro.
What can you explain both the findings with a single diagnosis?
Gist and mucosal.
You are right, na? Carcinoid can be at two
Carc-
places.
Yes, sir.
Gist may be at two places.
Yes, sir.
So you can explain by one pathology there. I was
What is
asking
the difference between a
Yes, sir.
Yeah, Rahul, go ahead. Yeah.
what do you understand by a synchronous lesion and what is a metachronous lesion?
So synchronous lesions, it happens at the same time, and metachronous is the primary happens and then the secondary happens. And in precautious, the secondaries appear before the primary tumor has appeared, sir. In metachronous, the
So,
second, yes, sir, second tumor secondary occurs after the primary, sir.
So if
so
this
do
is
you
a
think there are
tumor
two
which
separate
within
primaries here?
Mm. So there was no history related to the, sir, gist over the stomach, sir. So it may be, sir, synchronous. It can be synchronous, sir.
So if you think the synchronous lesion is there, a lesion occurring today and after 3 months, there is another lesion which is coming up. Is it metachronous or synchronous?
Sir, this the after 6 months, sir, it is uh, said to be metachronous, and within 6 months, if it is there, then it is called synchronous, sir.
Okay. And then the synchronous or metachronous occur in the same organ or the different organs?
Sir, different or it can appear. It can happen in different organs, sir. In different organs.
Right. Okay. Tell about HIPEC. What is HIPEC?
Sir,
And what
heated
is
intraperitoneal chemotherapy.
H?
Hyperthermic, sir. Hyperthermic intraperitoneal chemotherapy, sir. Given inside, it is given inside the peritoneal cavity, heated to around 41 to 43 degrees Celsius, sir.
Mhm.
And it is circulate for 1 to 1.5 hours, sir. 60 to 90 minutes.
Which chemotherapy is used?
Mm. Mitomycin C, sir, and oxaliplatin, sir.
And what is PIPEC?
Pipac, sir, I don't know, sir. Pipac,
PIPEC is pressurized aerosol.
pressurized aerosol.
Okay. So it is again the intraperitoneal chemotherapy,
Yes,
where you give under pressure the aerosol therapy. The
yes, sir.
chemotherapy given as an aerosol there. So that's the PIPEC therapy.
Yes.
Usually, which tumor you carry out the cytoreductive surgery? Which is the commonest tumor where it is done?
Sir, in peritoneal tumors, cytoreductive surgeries are done, sir.
Which tumor? Which is
Mm,
the commonest one?
cytoreductive surgery.
Mhm.
Peritoneum is the involved, which is the primary tumor where
Uh,
it is commonly used nowadays.
uh, oh, ovarian,
Ovarian.
Yes, you can.
Ovarian is
Yeah.
the
ovarian,
then colonic tumors and the appendical tumor.
colonic tumors.
Okay.
Do you know what do you do with remove in this cytoreductive process or cytoreductive surgery if there are multiple peritoneal mets? What are the principles of doing this cytoreductive surgery? If you know, otherwise it's okay.
Sir, I don't know, sir.
So you remove all the parietal peritoneum, the visceral peritoneum that includes the mesentery, leaflets all around. So you denude all the mesenteric vessels, remove any part of bowel which is involved, and remove the parietal peritoneum all over the from peritoneal cavity, and then you give that whatever chemotherapy is to be given, right?
Yes.
That is what the purpose of cytoreductive. Is it a curative treatment?
Sir, it gives a good prognosis, sir.
What
Survival rate,
do you
sir.
mean by cytoreductive surgery, principally? That means you remove the load burden of the tumor, right? So these are usually meant to prolong the symptom-free survival. It does not improve disease, survival overall.
Yes.
I think we can go for the second case. Otherwise, it will be too late.
Sorry.
Okay, Vedant. I think thanks from my side. And Dr. Kanaga, will you please advise?
I think we can
Kanagwal sir, are you there? Kanagwal sir, are you there? I think he seems to be out of the meeting.
Okay.
We can start with the second student
Second
if
one.
he is ready.
Vedant, you did very well. It's bipathology, two pathologies, very nice. Dr. Andre also, a very nice case you have presented. Very nice.
Thank you, sir.
Yes, we can go to the second case.
Thank you, Vedant.
Thank you, sir.
Madan, can you try sitting facing the light, Madan?
Yes. Sir, actually inside it's the
It's okay. It's okay.
Yes, sir. Am I audible, sir?
You're good enough. Good luck to you. Please
Yes,
start.
sir. Thank you. Good evening, all. The case presentation for the carcinoma breast.
Make it to full screen, Kanan.
Yes, sir. The chief complaint, a 65-year-old female, Mrs. Shankara Vadivu from Tirunelveli, which is a homemaker, came with a complaint of lump in the left breast for 2 years and ulcer over the lump for past 1 year. The history of presenting illness. Patient was apparently asymptomatic 2 years before, after which she noticed lump over the left breast, which was initially 2 x 2 centimeter in size, which gradually progressed to attain 5 x 5 centimeter in size. Also, patient complains of ulcer over the left breast for 1 year, over the lump for 1 year, which was initially 1 x 1 centimeter in size, which gradually progressed to 4 x 3 centimeter, which is associated with the pain and serious type of discharge, which is not blood-stained and not foul smelling. History of nipple retraction for past 1 year and no history of nipple retraction for past 1 year and no history of nipple discharge. No history of trauma to the breast, no history of fever, no history of swelling in any other lump in opposite side, no history of swelling in both axilla, no history of low back pain, no history of abdominal pain, no history of chest pain, breathlessness and cough, no history of headache or seizures, no history of significant weight loss or loss of appetite. Coming to the past medical history and surgical history, patient doesn't have any comorbid conditions like diabetes, hypertension, tuberculosis, thyroid disease, or cardiac illness. No history of any prior breast disease or surgery has prior surgery. No history of any radiation. No history of any hormone replacement therapy. No history of allergy to any drugs. In personal history, the patient takes a mixed diet. The appetite is normal and the sleep was normal. No history of smoking, alcohol intake, or substance abuse. Coming to the family history, no history of breast cancer, ovarian cancer, or any other malignancies in the family. Menstrual and obstetric history. The patient attained menarche at the age of 13 and attained menopause at the age of 50. The patient married at 19 years of age and had 1 child. First childbirth is at the age of 26, and she breastfed the baby for 6 months, and no history of use of oral contraceptive pills. The summary, summary to the history is a 65-year-old post-menopausal woman presents with a painless progressive lump in left breast for 2 years, with ulcer over the breast lump and nipple retraction for 1 year, associated with the pain and discharge, with no history suggestive of metastasis. On general examination, the patient is conscious, oriented, moderately built, and moderately nourished, and ECOG score is 0. Well hydrated, no pallor, no cyanosis, no clubbing, no pedal edema, and no
Let
significant
us
gentleman. Yes, sir.
just remember the history first, you know.
Yes, sir.
Okay,
Madan, you go back to the first slide. The faculty will
Yes.
finish the history part, then we move on to the clinical side.
Okay, sir.
Faculty, please take over.
Okay, you should not reveal the name of the patient and identity of the patient.
Yes, sir.
Okay, you
Yes,
have
sir.
shown here the name of the patient, you know. That is
Okay,
not
sir.
good, you know. Okay, you should
Oh.
always remember that you don't reveal the identity.
Yes, sir.
Okay, go to the
Sorry.
next slide. Okay, go to the negative histories which are there. Next slide.
Yes,
Yeah.
sir.
Why history of trauma?
The patient will have a traumatic lipomatosis of the skin, sir. If a patient is having any trauma, the fat in the breast tissue will undergo necrosis, sir. That will show us a lump, sir.
So is that a differential diagnosis?
Noted. It's not a differential diagnosis.
Like in your patient, do you think?
No,
the
sir. It's
trauma
not a
will be
differential
different?
diagnosis.
Why fever?
No, sir. Sir?
Why fever? No history of fever?
Because the patient is having an ulcer, sir, and also the patient is having cirrhosis, sir. Maybe there is a secondary infection to that, sir.
What is the age of your patient?
65, sir.
Okay, if you think of the fever, then you can think of the mastitis. But at 65, you will not get the mastitis. You know?
Yes, sir.
No history of swelling in the opposite breast. What does that mean?
The patient doesn't have any lump in the right breast, sir.
So if there is a lump in the right breast is there, what does that mean?
We have to evaluate for that also, sir. The patient can have bilateral breast carcinoma, sir.
Or
Any other benign conditions can be present in the other breast also, sir.
can you do metastatic breast carcinoma?
Yes, sir. It can be, sir.
So how will you differentiate whether it is a bilateral breast carcinoma, which is separate, or it is a metastatic breast carcinoma?
The bilateral, we can do genetic testing and any family history, sir, because the bilateral breast carcinoma is most commonly in the genetic type of breast cancer, sir.
Just on the history, can you have any idea?
We can ask for just a family history only, so we can't able to differentiate from the history itself. We can't able to differentiate that, sir.
If somebody has a lump in the medial quadrant, and there is another lump which is on the opposite breast on the medial quadrant, what do you think? What it would be? It's likely to be metastatic one. But if the lump in the outer quadrant is there and on other breast also it's on the outer quadrant, then it is probably a bilateral
breast carcinoma. Okay, sir.
Just by the site you can have an idea there, that whether it is a metastatic or it's a bilateral breast.
Okay, sir.
No history of low back pain?
We can suspect for a bony metastasis, sir, in the lumbar vertebra, so the patient can present with back pains.
Where does the metastasis occurs in the lumbar vertebra?
Most probably in L5, sir.
Okay. Which part of the vertebra?
It's in body, sir.
In the body, which part?
I'm not sure about that, sir.
You know, ramus of the You know about that? What is ramus?
The body, the part that is connecting the body and the transverse.
So if you see it on the plain X-ray, how does that look like normally? That part. If you see the plain X-ray of the L5 vertebra,
Okay,
how
sir.
does that look like? It's a rounded shadow on the both sides.
Okay, sir.
What's called an owl sign. No?
Okay, sir.
Okay. That is a site where the metastasis occurs in the body of the vertebra.
Okay, sir.
Why abdominal pain?
So the patient can have a ascites, sir, and also have a peritoneal mets. The patient, if it is a patient having ascites and it's infected, patient can have abdominal pain and fever, sir.
What other metastasis occurs in the abdomen?
Peritoneal metastasis can be there, sir. Liver metastasis can be there, and in umbilicus metastasis can be there, sir.
What else?
Ovarian metastasis can be there, sir.
What is that called as?
Krukenberg tumor, sir.
Will you get the Krukenberg tumor in this patient?
And no, sir, we can't because it's a post-menopausal age woman, sir.
Yeah, it is usually in the premenopausal. Doesn't mean that
Premenopausal.
it doesn't occur in the postmenopausal.
Most commonly in premenopausal age group, sir.
So what is the cause of spread? How does it?
Transcelomic,
Okay, and
transcelomic spread, and it can be also retrograde lymphatic, sir.
so retrograde lymphatic spread can occur in the postmenopausal also.
Yes, sir.
Okay. Chest pain, breathlessness, and cough.
If a patient is having a lung metastasis, usually it will involve first it will involve the pleura, sir. So the patient can have pleuritic chest pain, and patient have pleural effusion, sir. The patient can have breathlessness. If it is metastasis to the lung parenchyma, the patient can have cough and hemoptysis, sir.
Can there be consolidation?
It can be, sir. It can also be a consultation, sir. And
how do
that
you
can involve
clinically differentiate between consolidation and the pleural effusion? Clinically.
by percussion, sir.
Okay. What will happen?
In percussion, that in the pleural effusion, the percussion that will be dull note, sir. In consultation,
It will be dull again.
dull again, sir.
So how do you differentiate? You look for the vocal parameters.
Vocal parameter, sir.
Okay.
Okay, sir. Yes.
Or vocal resonance. Then
Yes,
only
sir.
in one case it will be increased. In pleural effusion it will be decreased.
Effusion, it will be decreased, sir.
Okay. Headache and seizures.
If a patient is having brain metastasis, sir, and the patient can have headache or seizure, sir, or any focal neurological deficit, the patient can present with weakness also, sir.
Okay. If there is a brain metastasis is there in a cancer breast, will it be HER positive or HPR negative?
It will be negative, sir.
HER positive. HER positive is more likely to have the brain metastasis.
Okay, sir.
Okay, next slide.
Dr. Madan, may I?
Yeah,
Yes,
please.
sir. The earlier slide, history of present illness, you have
Yes, sir.
presented all the points as if you
Yes, sir.
already know the diagnosis and you are asking questions. Am I wrong?
Based upon the appearance of the breast lump, on the age group, it is most probably malignancies. Can be a CA breast, sir.
So you have
just
already, from inspection only, you understood looking at it, or taking the history, probably you have not exposed it. You know that it is malignancy, and you are asking questions, knowing that the tumor is already cancer. Don't you think? Look at this. You are talking about metastasis. You are talking about other breast. You already have diagnosed the disease. Am I wrong?
No, sir.
Okay. All right. Carry on. Carry on. Next slide.
Which prior breast disease?
The patient doesn't have any benign or previous any benign or malignant condition in that breast, sir.
So which
Like
prior breast disease you are considering?
uh,
You are thinking either the patient had a breast cancer before, that is one possibility.
yes, sir,
But if
or
it is a benign one, then what is the possibility?
the patient if a prior patient can have can had a lump before, sir. Maybe they have undergone a lumpectomy for that.
Like somebody had a fibroadenoma is there, or fibroadenosis is there. Where are you more bothered?
We are more bothered about atypical ductal hyperplasia, I believe.
Atypical ductal hyperplasia is there.
Yes, sir.
Somebody had a atypical ductal hyperplasia in a positive family history. The risk is around 9 times.
Nice. Okay. Okay, sir. Okay, sir.
No osteoradiation. Where?
To the chest wall, sir.
For
It's in the chest wall or
maybe in the past she had a breast cancer and she's developing the
Yeah.
breast cancer on the other side now, or
Okay.
even on the same side also.
Okay, sir.
Which hormonal replacement therapy?
Patient can patient
Does it prevent the breast cancer or does it increase the breast cancer?
HRT will prevent the breast cancer, sir. No, sir, it will increase the risk.
No, it is
Because
the
in
type of the dose which is used.
okay, sir.
They are in fact more preventive now rather than the risk factors there.
Okay, sir.
Okay.
Yes,
Next
sir.
slide. Next slide. Next slide. Now, what family history you are looking for that?
Looking for any other malignancies in the family, sir.
What is the difference between hereditary breast cancer and the familial breast cancer?
The familial breast cancer, if it is the first degree relatives can have malignancy like breast cancer, sir. The hereditary, the genetic mutation will be there, sir. Like BRCA1 and BRCA2, the mutations will be there, sir, in hereditary breast cancer.
So what are the syndromes associated with breast cancer?
Cowden syndrome, Leaf-Rumani syndrome, ataxia telangiectasia.
Okay, next slide. Okay, next slide. Now tell what are the various absolute risk factors for the breast cancer and relative risk factors for the breast cancer.
The absolute risk factors to the patient is one is gender, sir, the female gender, and age, sir, and the genetic mutations. And other things are relative risk factors, sir. The other factors and are all relative, sir, like early menarche, late menopause, obesity, alcohol, nulligravida, age at first child. These are all and all relative risk factors, sir.
Family history is the relative or absolute?
Absolute, sir.
So you did not tell about that family history.
Family history is absolute, sir.
Atypical ductal hyperplasia is absolute or relative?
It's absolute, sir.
So there are 5 or 6 factors which are absolute, gender of the patient, age of the patient, Patient already had a breast cancer. Family history is there. Atypical ductal hyperplasia is there. BRCA1/2 is positive. So
Nice,
these
sir.
are the absolute risk factors, while others are the relative risk factors.
Relative risk factors.
Okay. Dr. Naren? Anybody else who wants to ask?
Again, the same thing. No history
Yes, sir.
suggested of metastasis. We are not yet in provisional diagnosis.
Sir.
Dr. Madan?
Yes, sir.
Last line, with no history suggestive of metastasis. It's the summary only. We have not presented the provisional diagnosis yet, but we are thinking of metastasis.
Yes, sir. We shouldn't have a prior idea. We should not think about the diagnosis first.
Yeah.
Actually, it should not be that way.
Before the differential diagnosis investigation, you should not talk about diagnosis. And there
Yes,
are
sir.
surprises. I'm telling you. You think that the breast lump of this aged old lady, similar presentation will be always breast cancer? No. There are surprises.
Yes,
Anyway,
sir.
continue.
Yes, sir. Shall I proceed, sir?
Next slide.
Yes. On general examination, the patient is conscious, oriented, moderately built, and moderately nourished. ECOG score is 0. Patient is well hydrated, no pallor, no cyanosis, no clubbing, no pedal edema, no significant generalized lymphadenopathy. The vitals is blood pressure 110 over 80 millimeter mercury in right upper arm in sitting position. The pulse rate is 86 per minute, regular rhythm, and saturation is 98% on room air, and the respiratory rate is 18 per minute. And local examination, the examination of the breast. After getting informed consent from the patient, both breasts are adequately exposed up to raised. And coming to the examination of the left breast, on inspection, on sitting posture by arms by the side, the left breast is asymmetrical compared to the right breast, and fullness seen over the left lower, inner, and outer quadrant of the breast, and skin over the breast. There is an ulcer of size 4 × 3 centimeter involving nipple and areola, ill-defined margin, averted edges, and floor is necrotic tissue with a serous discharge. And left nipple area complex is distorted, dimpling is present, and engorged veins are there, and no purely orange is seen. And left arms and thorax are normal, left supraclavicular fossa, there is no fullness seen. This is the clinical image of the patient. And this is the ulcer which was described as. On examination, on raising both arms above the head, left breast lifted upwards along with the lump compared to the right. The lump becomes prominent, no purely orange, and the nipple area complex is distorted, and dimpling is prominent. On bending forward, the left breast does not falls on bending forward. And on palpation, arms by the side, there is no warmth, mild tenderness is there, and lump of size 5 × 5 centimeter in left inner and outer quadrant involving the retroareolar region, irregular in shape, uneven surface, hard in consistency. The skin over the lump is not pinchable, does not move along with the lump does not move along with the breast tissue, and it's also fixed to chest wall and underlying pectoralis major. And also there is an ulcer of size 4 × 3 × 1 centimeter involving left nipple and areola with distortion, irregular shape with ill-defined margin, and base formed by the lump, which does not bleed sun touch. The palpation of the left axilla, a single mobile non.
Dr. Madan, please go back to the earlier slide.
Yeah.
No, not this one. The palpation of the breast. Okay, next. This is it. Fixed to chest wall and underlying pectoralis major muscle.
Yes, sir.
Can you elaborate it a little bit?
The lump does not actually the lump does not move along with the breast tissue, sir. On examining the lump, when we move the lump in the which is parallel and perpendicular to the pectoralis major muscles, it's not mobile, sir.
So it is fixed to pectoralis major. Then what is the chest wall?
The chest for chest wall, that lump does not falls freely on bending forward.
See, both are not similar, no? If it is fixed to pectoralis major, there will be some mobility. But if it is fixed to chest wall, it will be absolutely immobile. So If you have written chest wall, that means it is already crossed through pectoralis
Crossed
major.
with the pectoralis major muscle. Yes, sir. Yes,
Yeah,
sir.
so both should not have been mentioned actually.
Okay.
Anyway,
With this
comments
fixed-
are also
This fixed-
invited from the better people.
It is fixed to chest wall, sir.
Yeah. Okay,
Okay, sir.
go ahead.
A palpation of the left axilla, a single mobile non-tender anterior group of lymph node of size 2 × 2 centimeter, which is round in shape and firm in consistency. On the palpation of the left supraclavicular fossa, there is no lymph nodes palpable. The examination of the right breast and axilla is normal, and there is no right supraclavicular fossa lymph nodes are enlarged. The systemic examination, CVS S1 S2 heard, and the respiratory system, bilateral air entry is present. Per abdomen, soft, non-tender, no palpable mass, bowel sounds are heard. In PV, the bilateral fornices were free. In digital rectal examination, there is no mass or nodule palpable. In spine, there is no tenderness. And in CNS, there is no focal neurological deficit.
In abdomen, which palpable masses were you looking at?
If it is metastasis to the ovary, we can palpate for the Krukenberg sir.
It's 65, no?
Yes, sir.
So Krukenberg happens in?
Premenopausal, sir.
Yeah.
Most common in
So which
premenopausal.
palpable mass? Which palpable mass? Hepatomegaly, na?
Hepatomegaly,
Liver
sir.
mass. Liver mets. And liver mets
Yes, sir.
will go through
Blood, also
hematogenous
blood,
state.
hematogenous, sir, bloodstream.
Yeah. Okay, please carry on.
And based on the clinical and history and clinical examination, my probable diagnosis can be a case of carcinoma left breast, T4C, N1M0, stage 3B. It is a locally advanced breast cancer.
No, the liver metastasis is always a hematogenous metastasis.
It can be also it can be also by lymphatic, sir, but most commonly by hematogenous, sir.
When it will be lymphatic? What is the location of the tumor when it will be lymphatic? It can be lymphatic.
Upper outer, sir.
Lower inner quadrant.
Okay, sir.
Okay, if it is the lower inner quadrant, it is, then in that case it is like maybe lymphatic metastasis to the falciform ligament. No?
Okay, sir.
What do you understand by chest wall in case of cancer breast?
The chest wall includes ribs, intercostal muscles. Serratus anterior or latissimus dorsi, sir.
Latissimus dorsi doesn't come here.
Serratus anterior.
Latissimus dorsi forms what? What is the boundary? Where it is forming the boundary?
In the axilla, sir.
Which is the posterior boundary.
Posterior boundary of axilla.
It is not the chest wall, no?
Okay, sir.
Okay. Now, you have told us about the supraclavicular.
Yes, sir.
You have told also about which other lymph nodes?
Internal mammary nodes and
internal mammary and
inferior clavicular nodes.
Infraclavicular.
Infraclavicular nodes.
Where you will look for the infraclavicular nodes?
At the lateral end of the clavicle, between clavicle and first rib at the lateral end of the clavicles.
And where you look for the internal mammary?
Internal mammary, we can't able to palpate, sir. If it is enlarged, there will be a dull note over the lateral border of the on percussion. There will be a dull note on the lateral border of the sternum, sir.
Okay. So what is your diagnosis?
The diagnosis is the probable diagnosis. It can be a carcinoma left breast. The staging is T4C N1M0, stage 3B. It's a locally advanced breast cancer, sir.
Why T4C?
The patient is having both skin involvement and chest wall involvement, sir.
Mhm. Why you say chest wall involvement is there in this patient?
Because the lump is lump does not move with the breast tissue, sir, and also lump on lying on bending forward, the breast does not fall, sir.
Does it move or not?
No, sir.
Only then you can say it's the chest wall, no?
Yes, sir.
If there is no mobility is there,
Yes, sir.
except in which area it may be mobile but
Sir.
still T4C.
It's in, sir. If it is in the upper outer quadrant, if it is involving the serratus anterior muscle, it can be mobile, sir.
Yes. So if it is on the serratus anterior, then it can be mobile. But
It
otherwise,
can be mobile, sir. Otherwise, it's if it is T4C, usually it will be not mobile, sir, except for that upper outer quadrant lump, which is involving the serratus anterior muscle.
what is T4A?
T4A is the involvement of the skin, sir. There's ulceration, fungations, or nodules will be there, sir.
Which skin involvement doesn't change the stage of the disease?
Sir,
Which skin involvement doesn't change the stage of the disease?
UD orange, sir.
UD orange? UD orange is T4A. Okay, there are three things in the T4A. It is ulceration, the skin nodules are there, or the UD orange is there.
Oh.
But like nipple attraction, puckering,
Yes,
dimpling,
puckering, dimpling. Yes,
they
sir.
do not change that. No?
Yes, sir.
Okay. So what are you
Okay.
planning for this patient? Yeah.
Dr. Madan,
Yeah.
Yes, sir.
can tell me a few differential diagnosis. If you think of anything non-malignant looking at the picture and your history,
It can be a Paget, sir, but because the
Paget
nipple area
Paget
complex
is not a
is
non-malignant, it is malignant only.
sir,
It on the nipple.
it can be
That's why actually I'm pestering you that breast cancer, no, two at least differential diagnoses which are not malignant but mimics malignancy very strongly. One is tuberculosis, and second one
sir.
is chronic granulomatous mastitis. Very difficult to diagnose without biopsy.
Okay, sir.
So differential diagnosis, you should not, you have said provisional diagnosis. You have written diagnosis, but where is the tissue diagnosis? Without doing tissue diagnosis, how can you write T4C N1M0?
Yes, sir.
It is the malignancy classification. No?
Yes, sir. Yes.
So that's why you will have to think, because it is a clinical meeting, no? So we are doing physical diagnosis. After that, differential diagnosis, after that investigation, then that investigation will tell you whether it is malignancy or non-malignancy.
Yes, sir.
Okay. So
Yes,
yes,
sir,
go
understood,
ahead after diagnosis. Go ahead. What did you do? Investigation.
Yeah, for investigations, as usual, there will be triple assessment, sir. Actually, the clinic examination part is over. We'll proceed with the radiological investigation and pathological investigation, sir. In radiological investigation, we'll do first. We'll start with ultrasound breast, sir.
That's why I'm telling you that you have presented the case very well. I do not deny it. And you have been asked also very good questions. You have stood up very well. But it looks like you knew the diagnosis and you are presenting the case. But diagnosis comes much later. No? When it is a fresh case, it will come to your OPD, to your front. Then you'll start from asking questions and finish with differential diagnosis, then investigation. Triple assessment is a procedure for malignancy. You do not know whether it is tissue-specific malignancy or malignant disease or not. Don't you think so?
Yes, sir. Yes.
So
Without
you
knowing,
tell us the investigations. What will you do? Then you will do triple assessment. Of course, if it comes malignancy.
yes, sir. I'll do first ultrasound breast, sir.
You have an ulcer staring at you. Tuberculosis could also be in the
Can take up
gamut of
incisional biopsy. I can take, sir.
Sir, what is the standard way of investigating a breast lump of 65 years old female who doesn't have any risk factor for getting a malignancy?
But for evaluating the breast lump, the basic standard is triple assessment, sir. Once after the clinical examination part, we will proceed with the radiological and pathological. We will start with the USG, sir. As it is a
Yes.
65-year-old, as it is a 65-year-old male, we can do sonomammogram, sir.
Mammogram.
Yes, sir.
Well, okay.
And after that imaging, we'll proceed with the
Do you think
pathological, sir.
this breast picture which you showed us is very easy to do a mammography in this breast?
No, we can't able to do mammogram in this case, sir.
See, be matured and tell us what you will do practically on this patient. Now that you have examined the patient, you have come to a more or less an idea. So you will do an
Yes, sir.
ultrasound examination. That I understand. Anything else?
Yes, sir.
Okay, you say, tell me that assessment, triple assessment only. First is you say
Yes.
radiological, okay, ultrasound you have done. Anything you will do
Yes,
with,
sir.
along with ultrasound?
I'll do biopsy, sir.
So what type of biopsy nowadays you prefer?
Actually, the patient is having an ulcer associated with we can take incisional biopsy along with the cortical biopsy, sir.
You know, many times this type of ulcer do not have malignancy, but you have got an irregular hard mass in the breast and you are going for ultrasound. What should be your way of doing biopsy? Nothing.
Trust me.
Needle biopsy don't do these days.
What's it?
Needle biopsy you don't do.
Yes, sir. We
Core needle,
will
core
do,
needle.
sir.
Core needle
needle
biopsy you will do, that is it. But only restriction is that you will have to do the surgery very quickly if it is malignancy or it will spread. So
Yes,
you
sir.
do ultrasound and then you'll try to do the tissue diagnosis. So whatever way you want to do, you take an edge incision biopsy or a core needle
Yes, sir.
biopsy, whatever
Cortical
it is,
biopsy.
you'll have to do, then you'll have to come with tissue diagnosis.
Yes, sir.
Proceed. What investigations you will do?
It's ultrasound, sir, and we'll do the core needle or incisional biopsy for this patient.
Okay.
And then for we'll do metastatic workup, sir. We'll do blood investigations, LFT, and we'll do CECT chest and CECT abdomen, sir. And we'll do bone scan to rule out bony metastasis, and we'll do PET CT, sir.
PET CT.
Yes, sir.
So when you had to come to PET CT, why bones?
Yeah, exactly.
Why CT?
Metastatic workup. What is better than
Why
PET CT?
CT abdomen?
Even PET MR
It
also
is
you can
like
do.
you have mentioned every radiological investigation you knew.
Yeah.
Stage the disease. To confirm the diagnosis, you need a tissue diagnosis.
Tissue
And
diagnosis.
mapping of where all it has spread the tumor locally,
Yes, sir.
the E stage. E-wise ultrasound, that will help you.
Yes, sir.
Then to confirm the disease, a core needle. What all will you see in the biopsy? What all will you see? What all information you need from the pathologist?
Polar emission, sir. I got it. Yes.
What all information do you want to get from the pathologist on the core needle biopsy report?
Yeah, that's it. First thing is that. Say, for example, Dr. Madan, if the pathologist says that it looks like giant cells are there, Langhans stripes, okay, so it is a tuberculosis,
Yes,
then
sir.
what will you do PET CT?
No, sir.
So that's why you need a tissue diagnosis. Dr. Raman is asking you that only. What will the pathologist tell you on that core needle biopsy? First thing, it will understand cytological presence of malignancy.
Malignancy, yes, sir.
So that is it. Don't be
Evidence
challenged
of,
by us. We are just asking logical questions. You are becoming
Yes.
nervous. Don't be nervous. You are presenting very well.
Yes, sir. Yes, sir. First, in tissue biopsy, we must know that there's a evidence of malignancy is present or not, sir.
Yes, yes.
Ah.
And if it is malignancy, the second part of Dr. Amar's question, if it is malignancy, what type? It will tell.
They will tell about if it is an invasive breast carcinoma, They will tell about what type of invasive breast carcinoma is there, sir. And we also do IHC markers like ER, PR, and tretinoin in that sample, sir.
Yes, exactly. That's what Dr. Aman wants to know.
Yes, sir.
Yeah.
First is epithelial, non-epithelial, then
Hmm.
epithelial, ductal or lobular,
Lobular.
then the IHC markers,
Yeah.
HER2
Yes, sir.
status, ERPR status.
Yes, sir.
So now it comes that it is invasive ductal ERPR positive. Now
Yeah.
how do you want to proceed?
As it is an locally advanced breast cancer, we'll proceed with NACT, sir. Any new adjuvant chemotherapy.
No.
Phase.
Now you will do investigations
The
to
beta
stage the disease.
disease. Yes, sir. I take what Kapil do, sir.
So metastatic workup confirms your staging as T4C,
Staging
N1, M0.
and one M0.
Now how
Yes,
do
sir.
you proceed? Yeah.
Actually, Madan has ended his presentation in this slide, right?
Actually, yes,
He
sir.
has ended his presentation on this slide. So that's why he is also getting confused. How to progress from this slide, Madan?
We'll after this we'll start with the treatment, sir. As it is a locally advanced breast carcinoma, we'll start with a neoadjuvant chemotherapy, sir.
So how will the marker status
What will you do? You have become inaudible.
Sir, can you? I'm audible, sir.
Now audible.
Yeah, you're audible.
Yes, sir.
One is triple positive, one is triple negative. What all will go in your mind thinking of what to do next?
First, after the based on the molecular classification, the treatment will vary, sir. The patient is if he's having a triple along with the ERPR positive, the patient is also having a HER2 positive. We'll also start targeted therapy, sir, along with the neoadjuvant chemotherapy.
What targeted therapy and what are the side effects of it? What would you rule out before giving that targeted therapy?
Trastuzumab and pertuzumab are the targeted therapies now available, sir. Sir,
So what
can I get a
major side
moment?
effect will that? Yeah.
I'll just plug in the charger, sir. A minute, sir.
Yeah.
Yes, sir. The targeted therapy we have is trastuzumab and pertuzumab, sir.
What major side effect or toxicity you want to check before starting it?
Cardiotoxicity.
You would like to do a 2D
2D
echo
echo
cardiography
to
before
look,
doing that.
sir.
And baseline heart defects,
Okay, sir.
extraction,
Yes, sir.
RVSP. Okay.
Yes,
Rest.
sir.
Oh, so ERPR positive, ERPR negative. What thoughts are running in your mind? Triple positive, triple negative, what marker status? How do they end up in prognosis? Which is better? Triple negative, triple positive,
Triple
or
positive has
two
better
positive, or
outcome.
two negative? Okay.
Triple positive has better outcome than triple negative, sir. And based on HER2 new positive has better outcome than HER2 negative, sir.
So HER2 new negative implies better tumor biology. But now since we have targeted therapy, so the outcome is better overall with HER2 positivity. You
HER2
understand?
positive, sir.
HER2 negativity
Yes, sir.
means less tumor growth. HER2 negativity means less tumor growth, better tumor biology. But HER2 positive, we have therapy, so we can control it better.
Yes, sir.
What neoadjuvant options do you know of, and what would you like to offer?
The first line drugs are taxane, sir. Taxane containing drugs, adriamycin, cyclophosphomides, and 5-fluorouracil we can give, sir. And another regimen is CMF, sir. Cyclophosphamide, methotrexate, and 5-fluorouracil, sir.
Okay. And regarding the ERPR status, how does that help?
In ERPR status, you can start hormonal therapy, sir, but
That comes only much later for adjuvant.
much later, sir. Yes, sir. We don't start a neoadjuvant hormonal therapy.
So,
It will be as adjuvant, sir.
ERPR hormonal therapy is a matter of concern for early breast cancer.
Yes, sir.
In locally advanced, suppose such a state comes when the patient is considered near cured or R0 after neoadjuvant chemoradiation, after surgery, then tamoxifen may come into picture. So how many
Okay, sir.
cycles of neoadjuvant would you want to give?
First we'll start first usually first 2 cycles we will give, sir. After that we will evaluate the patient based on the RECIST criteria, sir.
Okay.
If it is a complete responders or partial responders, we'll do the surgery and then we continue that.
That is
Continue
why
the
in investigations to stage the disease, you needed a baseline PET CT.
okay, okay, sir.
So you could
How
apply the
optimistic are you
RACIST.
that you will be able to do surgery or clear it by surgery when it is fixed to chest wall? Go back to Holstein days.
Sir?
The tumor is fixed to chest wall. So
Yes,
what is
sir.
the chance of getting surgically clear?
It's very less, sir.
So what will you do?
The
You have
best we can.
given new adjuvant, then you will reassess the tumor,
Yes, sir.
but it is fixed to the chest wall.
Yes, sir. We'll if it is metastasis to any other places, the purpose for our chemotherapy is to be palliative, sir.
Why do you give the neoadjuvant chemotherapy? What is the rationale of that?
To downstage to reduce the tumor burden, sir. Because as carcinoma breast is a systemic disease, there will be micrometastasis can be there, sir. So because as it is already a locally advanced breast cancer, and the micrometastasis can be more, sir. So basically, the main purpose of the neoadjuvant chemotherapy is to decrease the tumor burden, sir.
What else?
And it's an advanced disease. It will be helpful for us to after downgrading the tumor, it will be very helpful for to operate, sir, and we can give the rest of this thing as a adjuvant chemotherapy and RT, sir.
It will give you in vivo chemosensitivity,
Uh, also,
control the micromets and negative margins.
You know, what are the various theories about the spread of the cancer breast? Then you can answer this question. What are the various theories for the? Madan, are you there?
He got locked out, sir.
Yeah, looks like, yeah.
He has got locked out, sir.
I know, I got it. I think his connectivity is not that great.
Yeah, yes, sir.
At the beginning only, before when we have the trial only, he had the same issue. Let us see. He's back, sir. He's back.
Are you back?
Sir, he's back, sir. He's back, sir.
Yes, sir. He's.
So you were telling about what are the various types of theories about the spread of the breast cancer. Madan, are you able to listen me?
Madan, are you connected? You remove the headset, Madan. Use the computer directly. Please log out and log in. Remove all the headsets and other things. You use the system microphone.
Your internet bandwidth is not so good. You can stop the video. Let just the audio be. Yeah, you are audible. Sir had asked you the modes of spread of breast cancer, theories behind it.
Madan Kumar.
Okay, class.
Madan Kumar, are you with us? Do we have anyone of the colleague of Madan Kumar joined in this Zoom?
Sir, I'm audible, sir, now.
Yes.
Sorry, sir. I don't know what happened, sir. Sorry for the inconvenience, sir.
No problem, no problem. You please switch off the other system if you have logged in two devices.
Yes, sir. I'm just presenting from my friend's phone, sir.
No problem at all, no problem. But then keep the
Yes,
device
sir.
at a fixed point. Don't keep on moving. Keep the device at a fixed point.
Yes, sir.
Okay. Faculty, kindly take over, sir, please.
Dr. Madan?
So post
Yes, sir.
neoadjuvant, you find a partial response.
Yes,
What
sir.
would you plan now?
I will continue the first two cycles. We'll assess that if a patient is a partial responder, will in this case we'll proceed with the other cycles of chemo, sir.
So you completed your planned neoadjuvant and there is partial response. What would you offer the patient now?
We'll change the regimen, sir.
No, you got partial response. Na neoadjuvant cycles you have completed.
Because as it is fixed to the chest wall, we can go for RT, sir.
So you didn't ask in what response. Partial response is with respect to which area, na? So maybe the
Yes, sir.
chest wall
Maybe there
fixity
is a
has
partial
improved with the
response to
partial
the
response. So you always have to, before the PET, examine the patient.
yes, sir.
So now chest wall fixity has reduced. It is just fixed to pectoralis major. So what do you plan?
Yeah. Radical mastectomy.
What will you plan?
We'll plan for radical mastectomy.
Okay. Okay. Why not modified radical mastectomy only with partial pectoralis major excision?
In radical mastectomy, we'll remove the entire of pectoralis major and minor, sir.
Okay. So what all will you remove in radical mastectomy?
In radical mastectomy, the breast, the skin over the breast, nipple area complex, level 1, 2, 3 lymph nodes, sir. Uh, the pectoralis major and pectoralis minor muscles, sir.
Do you remove the whole of the pectoralis major in radical mastectomy? Do you remove whole of the pectoralis major in radical mastectomy? What is classical Halsted mastectomy?
Spread, not forward, that's it.
How many parts are there of the pectoris major?
There are two parts, sir.
Yes. What are those two parts? One is the sternal part and another clavicular part.
Okay, sir.
Okay. So do you remove both or remove only sternal one? Okay.
We remove
Leave the
sternal part,
clavicular.
sir.
Okay. Only the sternal one is removed in radical mastectomy.
Okay, sir.
Do you know any
Okay, sir.
higher mastectomy than the Houston mastectomy? Urban's mastectomy. Have you heard about that?
Again, sir.
Urban's mastectomy. Where you remove whole of the chest wall. Yeah. Okay, so means you are going to remove the cartilage, ribs along the intercostal muscles. But that is no more done. It is too morbid a condition. So it is no more done.
Yes, sir.
But you should know about that. Like in this patient,
Okay.
which is fixed to the chest wall, that is one of the possibility. Very radical surgeon will go ahead and do the Urban's operation in that.
Okay, sir.
What are the various type of modified radical mastectomies?
Auction class, parties, madams, and the Scandi, sir.
Okay.
These procedures are based on the how we deal with the pectoralis minor, sir.
Mhm. And how much is the axillary clearance when you're doing the medical MRM?
Axillary clearance, we usually remove the level 1 and level 2 nodes, sir.
Okay.
Uh,
What are the nerves you save when you're doing the
the nerves we have to say is long thoracic nerve, sir, and
Yes.
medial pectoral nerve, intercostobrachial nerve, sir.
And
Now to latissimus nerve.
you have to save that now to latissimus dorsi.
Yes, yes, sir.
Okay. So you have to specifically save the nerve to serratus anterior,
Nerves to
nerve to
anterior
latissimus dorsi, and the medial
and
pectoral nerve here.
in medial pectoral nerve and intercostobrachial.
What you do with the intercostobrachial nerve?
If we damage the intercostobrachial nerve, the patient will have lost sensation in the medial part of the arm, sir.
Okay. Now, when you are doing the axillary dissection, what are the various precautions you take?
The precaution we should take, we should not go beyond the axillary vein, the superiorly, sir.
Mhm.
And medially and inferiorly, we should not go beyond the angular vein, sir. The bifurcation of the angular vein.
Okay.
And in the lateral and posterior part, up to the scapularis only, sir. We should not go beyond that.
Now, if you go superior to the axillary vein, what will happen?
We make brachial flux.
Hmm?
We may get damage. The actually the artery will be there, sir.
And the brachial plexus will be there.
Brachial plexus will be there.
And these patients will have a very high incidence of the lymphedema.
Severe,
Lymphedema. Yes, sir.
severe lymphedema.
That is why you should
Yes.
not go above that. Yeah.
Yes, sir.
Okay. Now, is the PET scan a
So-
standard for the cancer breast? In all cases, we should do the PET scan.
No, sir. In selected cases,
What is the problem if you do PET scan in all cases?
it's not indicated, sir. And
What are the fallacies of any PET scan?
it will enhance also the some active regions in the body, sir.
Infective lesions also it will pick up.
Yes, sir.
Okay, because FDG will be higher in the infective lesions.
Infected
It
regions.
can pick up that. And if somebody has got a small nodule or somewhere you find that lesion is there, and you will think it is the stage 4 disease, but in
Stage
fact that
4
is not the
disease.
stage 4 disease. So that is the
Yes, sir.
fallacy of the, that is why PET scan is not a standard in all cases of cancer breast.
Okay, sir.
So what do you understand with sonomammography? You said that sonomammography. What is the meaning of that?
It's a high voltage. It's a mammogram. It's a ultrasound only, sir. But
Is
it's
it a mammography or ultrasound?
It's an ultrasound, sir.
It's an ultrasound, yes. It is high resolution ultrasound.
High resolution ultrasound.
Yeah. So it is not,
Yes, sir.
because mammography has got a different machine. Ultrasound has a different
sir.
machine. So this
Yes, sir.
sonomammography is the term which is used for the ultrasound, not for the mammography.
Okay, sir.
Have you heard the name of contrast enhanced mammography? CEM?
That no, I never haven't heard of it, sir.
Okay. Tell which is the best investigation for cancer breast? Imaging investigation. Ultrasound, mammography, PET, MRI.
Best is MRI, sir.
Sorry?
MRI, sir.
MRI, yeah. So MRI is the best investigation.
Yes, sir.
And yeah, in any case of doubt, you can go for the MRI.
Okay, sir.
Now, I was asking you about that. What are the various theories for the breast cancer spread? Have you heard the name of Halstadian theory?
Yes, sir. Halstead theory and one new theory is there, sir. About the name.
Fisher theory.
Yes, sir. That
Halstadian concept and the Fisherian concept.
the Fisherian concept that Halstead is transelomic spread, sir. In the new concept is that metastasis has happened even before, even at the development of the lump, sir.
So Fisher said that this is from the day one is a systemic disease.
Systemic disease.
So that's what I was asking about the neoadjuvant chemotherapy. One of the very important component of neoadjuvant is it takes care of the micrometastasis.
Micrometastasis.
Okay. Australian concept is that it is a stepwise spread is there. That it will, from the breast, it will go to the axillary, then it will go to the apical node, then it will go to the supraclavicular node. But both theories are not absolutely correct. So nowadays, what is the next theory which has come? This is called a spectrum concept.
Okay, sir.
Spectrum concept, where both the things are correct.
Okay, sir.
And that is why you are doing a combination of the neoadjuvant therapy along with the surgery to take care of both the things here. What is RECIST criteria for the evaluation of the response?
RECIST criteria that there will be 4 criteria, sir. Complete responders, partial responders, non-responders, and progressive disease, sir.
So what is a partial responder?
Less than less than 30%, sir. 20.
Less than or more than?
More than 20. More than 20, sir. If it is a partial responders, less than 30, and it's a progressive disease, that's the increase in the percentage, sir.
What is a complete response? How do you define that?
The patient will, the lump will be not palpable, sir. The complete response will be there.
Is it only clinical or it is based on the investigations?
Based on investigations also, sir.
Yeah, it is based on investigations. So it should be clinical plus investigation. Then only you can say
Investigation.
there's a complete response there.
Yes, sir.
In a case of LABC, can you go for the breast conservation therapy?
We can go, sir. It's an option, sir. If a T3N0 disease is there, the lump is only just 5 centimeter. There is no nodal disease. We'll just place a microchip in the lump, sir. Or after the neoadjuvant chemotherapy, we can go for a BCS. After that, we can proceed with the RT, sir.
What are the various ways to do the BCS?
We can do ultrasound guided wire localization, sir. And Maxseed is there, sir. That's a Maxseed is it's a chip-like thing.
What do you understand by BCS? What do you understand by breast? Yeah, what do you understand by that?
We'll just remove the lump along with the margin, sir. And after that, 1 centimeter, sir. We have to remove along with 1 centimeter of the normal breast tissue, sir. And after that, we have to give radiotherapy for that patient, sir.
Is the radiotherapy mandatory?
Yes, sir.
In the very early cases, you can sometimes avoid, but you're right that radiotherapy is mandatory in the case of the breast conservation surgery.
Okay, sir.
How do you reconstruct the breast after the breast conservation surgery? What are the various ways?
The oncoplastic surgeries will be there, sir. If it is that's in 2 steps, sir. Based on the percentage of the breast tissue removed, if it is less than 20%, we can do mastopexy, sir. If the more than 20% of the breast tissue is not there, we can go for local reconstruction, sir.
What is the local reconstruction?
We can get a mini LD flap, sir. Mini latissimus dorsi flap.
Yes. If there's a big breast is there, then which flap you can use?
Transabdominis.
Tram flap.
Tram flap, sir.
So transverse rectus abdominis flap.
Abdominis flap.
Okay, Dr. Aman, you want to ask anything? Otherwise, we can close here.
So in this, yes, sir. So in this case, you got the biopsy report. What particular things you want to check in that biopsy report? So you should check for the margins and specifically the chest wall margin that we were very concerned about. The pectoral side. If a radical mastectomy, then if those margins are free, if a modified radical, then the deeper margin. Also the number of pectoral fascia and also the number of nodes which are positive, which will define later if radiotherapy is required or not, adjuvant is required or not, and based on the ERPR status, need for tamoxifen and raloxifene. Okay.
Yes, sir.
You did great. You presented everything nicely and
thank you, sir.
Nice presentation.
Thank you, sir.
Anna sir, anything else to add, sir? Any other faculty would like to ask any questions?
No, it's okay now. Yeah, Dr. Kenga. Yeah.
Madan, do you have any doubts to be clarified?
I need to read on some things that some things I have to read, sir, again. Actually, it was a very nice thing. I learned a lot of things, sir.
Again, sir, with the permission of the faculty, can we close the session, sir?
Yeah, I think so. Yeah.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
And thank you, Madan. In spite of all the difficulty, you were able to successfully complete. I thank the other faculty who have had to leave earlier. And Aman sir, thank you. I wish you can join us now and then whenever Fridays are free for you.
Sir.
Glad to have you on board. Thank you very much. And with the permission of all the faculty and dear students, we call the session a close.
we'll meet up for the next week. Thank you very much.
Thank you, sir.
Thank you, sir. Good night, everyone.